that congenital abdominal insertion of extraocular muscle is not uncommon, and it can come in a picture of isolated or associated with other craniofacial syndromes. However, isolated abdominal insertions of oblique muscles are uncommon.
استني يا سحر.
My first case is 1 year old girl. Her mother was complaining from red fistula 4 months duration. There was normal birth history after. Both post-ophthalmic and post-medical history were normal. Her post-psychotic reaction is shown in this table. She can fix and follow very well, and both anterior segment and posterior segment were normal. Pre-operative assessment, she was having left ET, doing present diopter without glasses, and there was left limited abduction -3. So for left AT 20 present diopter with left limited abduction and globe retraction, I diagnosed the case as left weight type 1. And the decision was the left medial rectus recession 5.5 millimeters. And the first thing we did in the day of operation was force duction test, which was positive. And after suturing the muscle and cutting the muscle, I found this surprise that the insertion of the left medial rectus was slanted. It was about 3 millimeters from the limbus in the nasal part and 5.5 at the lateral part. And this is the video of the operation when I was calibrating the measurement. And I tried to make the site of the insertion more straight, but the globe wasn't aligned and wasn't in the upright position. So after taking the advice of my senior, I started to do a 5.5 millimeter recession from the same slanted insertion of the medial rectus muscle as shown in this video. To cross the insertion and make the eye in the upright position and normal position. And then I rated the sclera, and then I took the other suture, 5.5 millimeter from the same insertion. And this is the post-operative picture of the patient. She was orthophoric in prime position, with the limited abduction in the left eye -3. I searched literature about abdominal insertion in cases of weight retraction syndrome, and I found this paper discussing that the anatomical changes are also commonly seen in the weight retraction syndrome, including fibrotic changes also seen in lateral rectus and medial rectus muscle, anomalous insertion, middle lateral rectus muscle, hypoplastic changes in the muscle also in stripes, and attribute some of the anatomical anomalies could also occur as a result of primary innervation anomaly. Also, this is a case report of a typical restrictive strabismus secondary to an anomalous orbital structure, the same case as our professor Dr. Hala mentioned earlier this day. The patient presented with erythromas and limitation of eye movement due to an accessory extraocular muscle, which is seen in this arrow. This patient underwent surgery, and they thought that it's a weight case. And then the surgery was ineffective, so they tried to do a neuroimaging, and MRI resulted in extraocular muscle as we shown in this photo. My second case is 6 years old boy who was his father was complaining of vision of either eye outwards 3 years duration. Post-ophthalmic history was normal. He had a speech and normal birth history at term. Psychophysical retraction is shown in this table. His best corrected visual acuity was 0.5 OU. Both anterior segment and posterior segment were normal. Ocular motility examination revealed bilateral unequal inferior oblique overaction, +3 in the right eye and +2 in the left eye. And he had left XT 45 present diopter and distance 25 present diopter with a V pattern. So again, there was an intermittent XT V pattern with convergence insufficiency. So the decision of the operation was bilateral stent and lateral recession, the upper ball at 6 mm and the lower at 8 mm with bilateral equal inferior oblique recession. And after doing the right inferior oblique recession, it was uneventful and normal. And when I started to do the left inferior oblique muscle recession, I found this surprise that the inferior oblique muscle is anteriorly inserted, as seen in this photo. This is the distance between the inferior oblique and the lateralis muscle. And during the surgery, I tried to hook all the fibers of the muscle, and I placed my artery. And I started to do the inferior oblique muscle recession in the conventional way after taking the advice of my senior. And I started to suture the muscle with the Vicryl 600 absorbable suture. You notice that the muscle is not as usual, it's a little bit thin. Then I cut the muscle after complete suturing of the muscle. And I had the inferior rectus muscle to make the recession. Took my measurements and sutured it in the space. And this is the post-operative picture of the child. He was orthophoric at distance with the residual 10% diopter of intermittent XT at near and his free motility with no pattern. I searched the literature about abdominal insertion of the inferior oblique muscle and found two cases. One of them was large IXT, and abnormal fibers were found below the lateralis after its recession. Also, they are reported another case of inferior oblique abnormal insertion in case of upper cutaneous albinism, and also other anomalies of the other recti. This is another example of getting back abnormal insertion affecting the muscle function to its original insertion. This boy was having congenital fibrosis of extraocular muscle presented with ET20 plus diopter and limitation of abduction right eye and elevation and depression, and also a mild limitation in the other eye. And after doing function test, we found that the abnormal insertion of the medial muscle at the limbus, about 1 mm from the limbus. So we sutured the muscle and put it in its original site at 5.5 millimeters. And the patient is orthophoric with large limited abduction -2. There are also many published studies about abdominal insertion of the muscle as superior oblique, also giving picture of superior oblique palsy and inferior rectus muscle. My take-home message is abnormal insertion of extraocular muscle are not uncommon and most reported by surgeons during surgery. However, they may mimic palsy or common strabismus in some cases. The special abdominal insertion can be done during examination, as in case of anomalous superior oblique insertion manifested by severe superior